Thank you, sir. Myself, Dr. Divya Kumari, consultant Sharpside Center, Patna. My topic is outcomes of heparin-surface-modified versus non-heparin-surface-modified Iols in diabetics after phacoemulsification. No financial interest. Patients with diabetes mellitus develop cataract at an early age in normal population. There is disruption of blood-aqueous barrier even without clinically visible diabetic retinopathy. The phacoemulsification technique has improved significantly. Still, it induces trauma leading to blood-aqueous barrier breakdown. Blood-aqueous barrier breakdown can be measured by a machine called COVA FM600. And also this breakdown can be reduced by decreasing the duration of surgery, mechanical trauma to uvea, decreasing phacoemulsification surgery, decreasing the size of incision, and choosing clear corneal incision, and increasing the biocompatibility of IOL. Our studies centered on the improving biocompatibility of IOL. It compares clinical outcome of heparin-surface-modified hydrophobic acrylic foldable intraocular lens undergoing phacoemulsification in diabetic patients. Laser cell flare meter is most accurate and sensitive method to measure both clinical as well as subclinical AC flare. The two intraocular lenses were hydrophobic acrylic monofocal aspheric. One was IQ, another was CT Lucia 601 PY. The difference being 0 degree haptic angulation in acris of IQ group and 5 degree angulation in CT Lucia. Study design was a single center randomized control trial with sample size of 100. Primary outcome measures were aqueous flare, central macular thickness. Secondary outcome measures were intraocular pressure, visual acuity, AC depth, and endothelial cell count. Inclusion criteria were age-related cataract in diabetic patients with age more than 45 years and patient willing to give consent and ready for the follow-up. Exclusion criteria were any other ocular disease which might hamper visual acuity. Statistical analysis was done with SPSS 23. The demographic and laboratory parameters were comparable between the two groups. The difference of preoperative axial length corneal refraction implanted intraocular lens power between the two groups were not statistically significant. The mean aqueous flare of posterior polar cataract was found to be the least and hypermature senile cataract was found to be the highest. The two groups were comparable in their distribution of cataract. The preoperative aqueous flare values in operated eye were significantly higher in acris of IQ group. Intraoperative parameters like ultrasound time, total fluid aspirated, cumulative dissipated energy, and total duration of surgery were comparable. The mean UDVA and CDVA was significantly better in CT Lucia group on day 1 only. 58.5% of cases in CT Lucia group and 41.5% cases in acris of IQ group achieved a CDVA of 20/30 or better on day 1. However, there was no statistically significant difference in any visual outcome parameters between the two groups at any other point of time. There was no significant difference between the two groups in post-operative central macular thickness during any follow-up. IOP was comparable between the two groups. The mean endothelial cell count on post-operative day 1, the endothelial cell loss was 6.6% in Acrisoft IO group and 8.01% in CT Lucia group. At 1 year, it was 21.66 in Acrisoft IOL group and 19.52% in CT Lucia group. At the end of 1 year, CT Lucia group had better endothelial cell count. The difference was not statistically significant. No significant difference was observed between the two groups on CMT during any follow-up. Both the groups developed 1 case each of clinically significant macular edema. Acris of IQ group had 10 and CT Lucia group had 9 cases of macular edema on OCT without deterioration of visual acuity. CMT was found to be positively associated with fasting blood sugar with beta of 0.21 and a p-value of 0.07, keeping other factors like cumulative dissipated energy, axial length, duration of diabetes mellitus, hypertension, HbA1c, urine albumin, and age of the patient constant. The mean spherical refractive equivalence in acris of IQ group was minus 0.367 and CT Lucia was minus 0.23. These are the post-operative pictures. The previous study done by Ursel et al. Has found aqueous flare value to increase with increase in degree of nuclear opacity. However, our study could not find any relation between degree of nuclear opacity and AC flare. However, HMSC group had higher AC flare compared to the rest. This probably was because HMSC are higher than normal lens, has more diameter than normal lenses, and it causes increased rubbing of cataractous lens against iris pigments. We also noted ACIOL had higher aqueous flare values than PCIOL in bag. This might be due to the same reason. Urine albumin correlated significantly with preoperative aqueous flare in both the eyes. This might be because albuminuria heralds onset of systemic vasculopathy and is a powerful predictor of major cardiovascular events and might be associated with blood aqueous barrier disruption as well. Our study found significant correlation between preoperative as well as post-operative values. In our study, we found that flare values were not necessarily highest on the first post-operative day. Smaller incision sizes are related to lower value of aqueous flare. Our study could not find any correlation between aqueous flare and CMT at any point of time. This may be due to several reasons like IOL, eye drop Nepafinac 0.1% was added. Conclusion, HSM IOL were superior to conventional hydrophobic IOLs in diabetic patients with respect to anterior segment flare and endothelial cell count. However, no significant difference was found between the two IOLs in terms of CMT and IOP. Recommendation is heparin-surface-modified IOLs may be implanted in diabetic patients undergoing phacoemulsification, but long-term follow-up is required. Thank you.
Very nice presentation.
Thank you, sir.
Heparin-surface-modified lenses are the latest arrival in IOL implants. Now tell me one thing. How long did you follow your patients?
For 1 year, sir.
For 1 year. And what gadget you use to count the specular microscopy, or just slit lamp examination? And
we counted specular microscopy, sir.
So did you mention it over here?
I couldn't, but we counted specular. Endothelial cell count was counted by Topcon specular microscope.
Okay. And in all research work, they have said something about giant cell count, etc. Did you have?
We saw, sir, due to lack of time, I didn't add it, but we saw giant cells also, and it was not significant. Difference was not found. That's why I didn't mention.
Okay.
Nice presentation.